Another relatively rapid fire session. I hope you'll find it stimulating. And this session, I think, Alyssa, you're going to moderate. Is that right? Excellent.
That's right, yeah.
Over to you.
Thanks, Norman, and welcome everyone to our joint activity showcase. So we're going to be hearing now just short, brief presentations from a number of members of our research network. The first people we'll be hearing from is about our new GACD Masterclass, and our speakers are Mark Huffman and Lisa Hirschhorn. Whenever you're ready.
Okay, thank you, everybody. And unfortunately, Dr. Hirschhorn had to go to another meeting. So on behalf of her, as well as Brian Oldenburg, I'm very excited to talk with you and promote the upcoming implementation research masterclass on the science of scale up. And so this is a background on this program that'll be coming up next year. Brian wanted to make sure that we were incorporating this masterclass concept into the larger training that the GACD incorporates around implementation science. So we can think of the GACD Implementation Science EHub as a free resource platform to advance knowledge and practice in implementation science in relation to chronic non-communicable diseases. The link is shown here. There's also the Implementation Science School, as you think about increasing amounts of activities and participation. That's been an important part of GACD from very early on. Brian and others at GACD have had an important role in both of these. So when we think about a masterclass, you know, this was asked by the GACD leadership for the development of this. Why are we planning such a masterclass on the science of scale? And there's growing use of implementation research for targeted projects, thinking moving from a facility up to a district, province, and sometimes even at a national level. But there's less experience in studying and planning for scale, including in non-communicable diseases. And so this is really needed because I think many of us do the work that we're doing because we're seeking longer term and broader impact for improved health and healthcare. And there's a growing science and understanding of this scaling work, and there's sort of the scale up and the scale out, which I'll get into in just a minute. And we can use this type of programming to build upon a robust literature on scale-up frameworks and emerging sustainability at scale. So this is a nice paper by Ahrens and colleagues, and a couple of colleagues at Northwestern, Brian Mustansky and Hendrix Brown, that's looking at some of the differences between scaling up and scaling out. So scaling up is an evidence-based intervention designed for one setting, and it's expanded to other health delivery units within the same or really similar settings under which it has been tested. So you think of a district-wide rollout. But scaling out is when the evidence-based interventions are either adapted to new populations or to new delivery systems or both. And so there's type 1, 2, and the 3 is kind of the combo of 1 and 2. So type 1 is that the populations are fixed, but it's a different system of delivery. Whereas type 2, the delivery system is fixed, but it's a different population. So thinking about community-based interventions or community health worker-based interventions for patients who seek care in HIV treatment facilities, and having that be people with hypertension, for example, who might be seeking care at those facilities. Those would be some examples. So the goals of the masterclass are to review frameworks for designing and evaluating scale-up of health interventions, to understand how implementation research can help in the study and planning of scale building on scale frameworks, and a brief review of implementation research as part of that. Understand how to integrate a framework for scale up and implementation research into a research proposal, and be able to apply this knowledge to new research grant applications. So a key feature of this masterclass is actually, instead of individuals being recruited, it'll be teams. So 2 or more who have a plan for an extramural funding application that's in sight. So we're going to be asking for a funding opportunity application number, or, you know, RFA, something like that, so that this isn't just sort of, you know, masterclass in the theoretical, but it's very much in the practical. So we have a draft outline and agenda that we've been developing, and it'll be a combination of synchronous and asynchronous work. So for week 1, it'll be introduction to scale and frameworks. Week 2, implementation research and designing scale up. Week 3, understanding and measuring context and researching at scale. Week 4 is linking implementation strategies to context for your scale. And week 5 is a review of the participants' proposals. So the faculty are looking to really support the GACD members in their science of scale, not just in sort of the knowledge, but thinking of the Kirkpatrick method evaluation framework. You know, what's the actions that will result from this masterclass? We're really hoping that these will be not just submitted research projects, but funded research projects that lead to improvements in healthcare. I'd like to thank you all for your time and attention and for any questions.
Great, thanks so much, Mark. If anybody has any questions for Mark, please do put them in the chat box, and I'm sure he'd be happy to answer them there. At this point, we will move on right away to our next presenters. If we have the slides, please. Thank you. Our next presenters are Jill Murphy and Kenneth Fung, and they'll be talking about their mental health project adaptations during the pandemic. Jill or Kenneth, whenever you're ready.
Thanks, Alyssa. We're all set. So, hi, I'm Dr. Jill Murphy, and with me is Dr. Kenneth Fung, and we are presenting on behalf of the GACD Mental Health Program Coronavirus Impacts Group, or MH-Pronto. And we're going to be presenting very preliminary results from our GACD Mental Health Program COVID-19 Impact Study. Next slide, please. So I'd like to acknowledge the other members of the working group, as well as thanking the GACD Secretariat, especially Izzy, who's been incredibly helpful in helping us to coordinate and implement the survey and focus groups that you'll hear about in a minute. And I'm just going to hand it over to Kenneth for the next few slides.
Thanks. Next, please. So this is a quick turnaround study, and it consists of a survey component and focus groups. So based on the survey the team has developed, we've received 32 responses representing 21 projects between April and May of this year. And we held 2 focus groups in September, consisting of 22 participants representing 13 projects. These are all projects from GACD. Next. So just a very preliminary results putting together both the survey and the focus groups. So based on the survey, the majority of the GACD mental health research projects was substantially negatively impacted by the pandemic, especially on timelines, meeting the milestones, and implementing the interventions and data collection. Using the RE-AIM implementation science framework, the 2 components most affected were reach and implementation. And through the focus groups, we have really on-the-ground stories about just the type of challenges people experienced during COVID. The recruitment were highly affected by lockdowns, things that were about to go, but suddenly everything was locked down, clinics were closed, people were kicked out of the villages. And so it was very difficult to recruit. Similar with interventions, a lot of planned interventions, especially in mental health, were one-on-one or small groups or community theater. So all of that was a no-go. And so the researchers shared the challenges even when things were opening up, there was distrust, like, why are you in the village? Or why are you approaching me? Why are you standing so close to me? So it's been a challenge. That obviously would affect the data collection, because a lot of data collection originally were in person or led by peers in the community. And even if people were able to convert to virtual collection of data, the pre and post may not match anymore, because some groups may not have the intervention, or site differences. One country may adapt it to virtual, but the other may not. So it's hard to now amalgamate sites to compare. And finally, the researchers themselves were highly impacted. Some of the researchers were personally infected by COVID and had to recover from that, or family members dying from COVID, or had to do at-home work or childcare. There was research-related stress about behind timelines, and feeling like suddenly the researchers, there's a lot of uncertainty, and there's uncertainty about the importance of the project, and even team communication, especially if there are different sites or if it's hard to communicate with locals and peers on the ground. Next. And with these challenges, the teams were very resilient in adapting their methodologies as well as the target population. So we have some examples of moving from focusing on those with alcohol use disorder to focusing on family members, from screening only those with depression and those with alcohol use problems to screening everyone. It seems like everyone was impacted by COVID. There were new intervention modules that were asked by the locals to be developed. Originally, it was just a mental health basic education, but it was found that in this disaster, they need to add an extra module. How do you handle a disaster scenario? How do you even build trust with healthcare workers, people coming with masks and vaccines, as well as new research directions, because even though there were interrupted surveys, some used this as an opportunity to study the impact of COVID. Some of the research teams innovatively directly address COVID and help out with the effort, from providing PPE to disseminating vaccines, as well as their mental health intervention, to trying to educate the public about vaccines and misinformation. There were also some wider systemic changes teams have witnessed that were innovative. From in New York, homelessness were being sheltered into hotels for free, to in developing countries where methadone, which used to be not allowed to taken home, they were allowed to take home, as well as delivering medications like antidepressants, either by little scooters or by mail. So there were systemic changes that were also innovative. Next, I'm going to pass it on to Joe.
Thanks, Kenneth. And of course, in addition to the general innovations and adaptations that Kenneth has just described, we've all seen, as we're witnessing in this very moment, a massive shift towards the use of technology to adapt to the restrictions of the pandemic. So in the survey, about 30% of surveyed projects reported a shift to the use of technology for training, data collection, and intervention delivery. And challenges related to this shift by about 30% across the board of projects included limited access to technology, such as internet connectivity and devices by end users, difficulty engaging end users in the use of new technologies, as well as adapting interventions for training. And in our focus groups, we heard both pros and cons of the shift to technology. And so one of the pros related to reach. And so geographic scope might have been increased via the use of technology for some communities, and in some cases even led to outreach to diaspora populations. So the original intention and reach target populations of the projects may have been expanded via the use of technology. But of course, access to the internet and or data plans, devices, and things like that may have been prohibitive for certain populations. And so that created a barrier in terms of intervention delivery and engagement by projects. And of course, some people prefer in-person interventions even when technology or technological alternatives are available. And so this might have led to more dropout by participants and more difficulty in recruitment and engagement. Next slide, please. So finally, we looked at impacts related to equity. And of course, this is a massive topic that we're all aware of related to the COVID-19 pandemic. But just briefly, both survey and focus group discussion respondents reported a substantial impact of the pandemic on their target populations. And this is especially true in low and middle income countries. And across the board, both in low and middle income countries and high income countries, groups that experience marginalization were hit the hardest. These include women, seniors, lower castes, people with lower socioeconomic status, people who might be precariously employed, people living with disabilities, students, etc. Participants also spoke to the lack of physical and mental health infrastructure in a lot of settings, including people dying because of lack of oxygen and, really substantial strains on the health system in general, as well as on the mental health system, especially in low and middle income countries. We also heard a lot about the rise of substantial challenges that are mental health risk factors or related directly to mental health, including the rise of domestic violence, substantial and long-term interruptions in school access for children, increases in teen pregnancies, increases in suicide. And also, of course, there's differential and inequitable access to information, vaccine availability, and technology, both within and across countries and study contexts. We also heard a lot about inequities among frontline healthcare workers. So, for example, contract or staff that were not on contract had to take on more risk and more precarious employment during the pandemic. And this led to strains on their mental health and impacts on the project. We also heard a lot about how the pandemic has led to more open discussions about topics like mental health, racism, and social justice. And researchers in the GACD network are taking on a role as advocates and really feel the calling to engage in this sort of advocacy role, both on behalf of their own communities and the communities in which they're working. And so we also heard a clear message that funders should consider supporting and recognizing researchers doing advocacy as part of their role as researchers and part of their funded work. Next slide, please. And just to wrap up really quickly, as Kenneth and I both mentioned, this is based on a very preliminary analysis, especially of the focus group data. So our next steps are to finalize systematically the analysis of both the survey and the focus group. And we would like to disseminate the results via publication and continue to do so via the GACD network. And that's all from us. We'd love to answer any questions that you have, and thanks very much for your time.
Jan to take the floor, who will be speaking about minimum and optimum variables for multimorbidity. Thank you, Jan.
Yeah, thank you for giving me the opportunity to speak. Next slide. And yeah, the topic has been introduced, and I'm very glad to be able to represent a larger consortium here. Next slide, because I firstly need to acknowledge some funding by the NIHR, which is partly funding the project I'm talking about, and I'm obviously only representing my views and not necessarily those of the funder. Next slide. So I'm representing the Impact Consortium with the Global Health Research Group at the University of York, with partners in Bangladesh, India, and Pakistan most prominently, and we are working on reducing deaths and improving health for people living with severe mental illnesses, particularly from physical conditions, and to reduce the impact of depression and anxiety in people living with chronic physical conditions. And one topic, next slide, that we saw there from the beginning that was really highly relevant is the question of what matters to stakeholders in low and middle income countries when assessing the effectiveness of treatments and services for people living with multimorbidities. And that was not very well covered in research and practice back then. And the answer that we try to develop now is a core outcome set for multimorbidity studies in low and middle income countries. Next slide. A core outcome set is an agreed standardized set of outcomes that should be measured and reported as a minimum in all clinical trials in specific areas of health or healthcare. And today it's much broader, yeah, so it's also for clinical audits or for any type of research or evaluation activity, really. And there was some activity previously going on in this area, so there is a core outcome set for multimorbidity studies, COS-MM on the left hand of this slide. And just to illustrate what we're talking about when we're talking about outcomes, it's health-related quality of life, mental health outcomes, and mortality that were identified by stakeholders as the key things that all studies in this area should be reporting. And but that was developed without input from low and middle income countries. And on the right-hand side, the model was developed by input and collaboration in the multimorbidity working group of the GACD. And those are 8 outcomes that they came up with, but this was not based on either specifically targeted primary research or systematic reviews. Next slide. And that's what we are trying to develop here, because the development of a core outcome set has a established methodological approach. So after the definition of the target population outcomes, and we are developing here 2 core outcome sets effectively for prevention studies on the one hand and for treatment studies investing multimorbidity. And what we have done so far is a systematic review of studies that were in that space conducted in low and middle income countries, and have screened and extracted outcomes from a sizable number of papers that had been conducted in that area. And on the other hand, we have finished qualitative research, 50 interviews in 10 low and middle income countries, which is obviously not representing the world by any means, but still the first systematic exercise doing that to support such a work. And we are right now feeding this into a multi-round Delphi survey that we are conducting with stakeholders to identify what in this setting are now the most important outcomes that should lead then to a consensus meeting. And next slide, just finishing up, you can find out more about this, because this is obviously very brief, in the protocol for the project that we have published on our website at the bottom left, or you can immediately contact me because we are recruiting for the Delphi study now. So it's in low and middle income countries if you are or have access to people living with multimorbidity, or people experienced with living with multimorbidities, so like family caregivers, healthcare professional, policymakers and researchers, then we would be really grateful for any contacts. Thank you so much.
Thank you. Next slide, please. Thank you. So this is our study identifying effective primary healthcare service delivery models for integrated management of non-communicable diseases in low and middle income countries, and also resource constrained settings in high income countries. Next slide, please. Thank you. So this project is an opportunity basically, for global initiatives that are being funded by the GACD to join together, and initiatives that are focusing on research and interventions to improve primary care. So we'll be leveraging the capacities of all the institutions and groups that are partnering on this project. And so, to study the different models that are being tested to integrate NCD care into primary care. Next slide, please. Right. So, I think we all know that NCDs are the leading causes of deaths, and we all know that primary healthcare systems, particularly in LMICs, are not oriented to managing and caring for non-communicable diseases, although they do have a big role in providing care for NCDs. Now, there are approaches to service delivery models that are captured in literature, but there are evidence gaps relating to mechanisms for implementing these models, and also more attention is needed to measure service delivery elements that are essential for providing primary health care. And so we'll be using the Primary Healthcare Performance Initiative framework, which lays down the critical components of a strong PHC system and guides what needs to be measured to inform and drive efforts to improve PHC. And we'll be focusing on the service delivery processes, particularly under the PHCPI conceptual framework. And so we're studying, essentially we hope to learn from learnings of your projects to answer 4 questions. So one, what are the optimal service delivery models for integrated NCD care in different settings, under-resourced settings, how to implement the models, and what are the clinical and implementation process outcomes of these models. And lastly, what are the contextual factors which influence the models and the outcomes of these models. Next slide, please. Thank you. So this is basically how we're going about the study. So at the first stage, we're doing a scoping review of all the GACD funded projects. And over here, we are looking to identify projects which are working in LMICs or with vulnerable groups in high income countries that are providing interventions based at a primary healthcare facility or at the community level, and that are providing treatment or promotive, preventive, rehabilitative or palliative care. So after the scoping review, we will be contacting the research teams of the selected projects and putting together a working group. Along with the working group, we'll be developing a detailed protocol and also data collection tool. So one of them will be a self-administered survey to collect details on the funded research, and the second will be key informant interviews to expand on the reported elements. After this, we'll move into the data collection stage where we'll be sending out the self-administered surveys to the research teams, and We'll also be conducting interviews and collecting documents of the projects and doing a document analysis. In the scoping review that we are currently, that's the stage that we're currently at, we're also, we're also finding published literature on each of the projects and including those. Post this, we'll be moving to the data analysis, where we'll be using descriptive statistics to describe the components and outcomes of the different models of care. And there will be interviews, and through all of this, we hope to identify contextual barriers and facilitators that influence the delivery of care. And at the very last stage, we hope to disseminate the findings through the GACD network and identify context-specific optimal service delivery models for integrated management of NCDs at the primary healthcare level. For this project, we look forward to your support and to collaborating with all of you, and we'll be contacting the research teams of the shortlisted project soon. In the meantime, if there is anybody, if any of you are interested to collaborate and would like to reach out, please feel free to write to me. I don't think my email ID is mentioned in the PPT, but I shall put it in the chat box. Thank you.
Thank you, Jackie, for your introduction, and hello, everyone. My research study has been collaboratively undertaken with the Upscaling Working Group, and I'm examining the projects funded by the GACD 2019 Scale-Up Call. Today, I'm going to present our preliminary findings for one of our research questions, which is to identify the process and nuances of stakeholder engagement in the planning and development of multi-country and multi-sectoral collaborative scale-up projects. This slide maps the research collaborations involved in the 21 projects who have shared their planning stage documents for our study. The yellow color represents the funding agencies, as well as the location of the HIC, high-income country research partners. The blue color indicates the implementation country with the in-country research teams. The two striped countries, Argentina and South Africa, have both funding and implementation in the same country. Preliminary findings from our study indicates that in most projects, the lead investigators across these countries have a past history of working relationship, and this helps to build trust and good communications. Findings also indicate that the nature of relationship between the research partners drives the culture that exists within the scale-up project teams. It is therefore important that these partners develop a strong, positive, and respectful work culture, which can then flow to others working within the system. This slide shows the project-level breakdown of potential stakeholders involved in scale-up projects. I have completed 44 multi-stakeholder interviews across 19 projects with a representation from all groups except the target group of interventions. As can be expected, each stakeholder group has their resource constraints, issues, challenges, and enablers that motivate and engage them to partner in the scale-up study. Project-level preliminary analysis reveals a complex network of relationships and communications between the different stakeholder groups that are necessary to bring these teams together and keep them working together. Most projects have a process of stakeholder engagement and mention it in their planning documents as well. Some project teams additionally have established steering committees, advisory boards, scientific expert advisory groups to facilitate stakeholder consultation and engagement. 11 of these studies have identified specific frameworks, theories, and models to guide their stakeholder engagement, such as participatory approaches, IKT, the Integrated Knowledge Translation, the International Association of Public Participation, IAP2, among others. This slide shows that scaling up requires strong collaboration between different people for success. As project teams implement their projects, they are likely to encounter challenges and they have to learn to adapt and modify their plans in response to these. COVID-19 being an example of how project teams have learned to modify their original plans. We recommend that stakeholder engagement strategies are identified and clearly articulated during the planning stage so that stakeholders have identified forums and pathways where they can discuss their problems and challenges, knowing that they will be heard. If these strategies are supported by a framework or model or relevant to the project, it will provide a more robust structure for managing stakeholder engagement. And thirdly, since scale-up projects are long-term projects, If stakeholder engagement strategies can be evaluated at the end of studies or short phases, it will provide meaningful feedback on what worked well and what can be improved upon during future phases of the project. To summarize, developing a positive culture with strong, respectful partnerships, supported by clearly articulated communication forums or channels, and ideally supported by frameworks, can provide a healthy foundation for collaborative and sustainable scale-up projects. Thank you very much.
Thank you for this opportunity to present my reflections of the 2020 Meditation Science School. I'm Oluwatosin. I'm joining from Nigeria. Next slide, please. So I attended the Implementation Science School, having been introduced to implementation science by my mentor, Dr. Melissa Gladstone at the University of Liverpool. Primarily, I trained as a pediatrician and clinical researcher. This was my first experience with implementation research and implementation science, and it was a very great experience. My research interests are in child and adolescent health, precisely child and adolescent sleep health, mental health, and child development. Next slide, please. The Implementation Science School 2020, which was aired between 23rd October to 4th December, was a very great experience. I was privileged to attend that school, which was the first virtual one, and we had an intensive 2 weeks training experience. It was quite interesting and interactive. We had participants from 30 countries, and I am somewhere there, joining from Nigeria. And we had a lot of opportunities, networking opportunities, multiple teaching sessions. We had pre-recorded videos, plenary sessions with great faculty members. The small group sessions were quite interesting and beneficial for me. I was also in group 5, A5, with 5 other people, and we had to work on a project. I think all these helped to give me a very good experience and exposure to implementation research, especially as a first-timer. Also, we were introduced to the GACD EHub, and we were fortunate to be the first set of people to use the EHub, which is now free for everybody to use. It was also a very good resource, and I must say thank you to GACD for doing this for us. Even though the school was virtual, we were able to get a lot from it, despite the fact that we didn't have person-to-person contact. Next slide, please. Thank you. So my own personal reflections on the lessons I learned from the Implementation Science School in 2020. As I mentioned earlier, this was my first experience with what implementation science is about, and I could see that I had been involved in knowing the gaps. Most of my earlier research work was about knowing the gaps, knowing the burden, epidemiology of disease conditions, especially in my locality. And I got to know that implementation science is about closing the no-do gap. I mean, translating what is obtainable from research to practice. I also learned about different implementation science study designs and hybrid designs. And I think the climax for me was the theories, models, and frameworks. It was initially something that sounded very strange, but by the time the school was ending, and also together with the help of my colleagues, especially those in my subgroup, I was able to understand the various frameworks, especially the things like the precede, proceed framework, the REHAM framework, and I'm beginning to apply these frameworks to my projects. Personally, I'm doing my PhD in sleep science at the University of Witwatersrand, and I'm working on developing interventions that can improve sleep in adolescents in my area, especially in rural communities. Also, I benefited a lot from the tips for developing my career in the global world, especially the role of relationships, funding, mentorship, planning of my career path and progress. And I remember then the faculty who took us emphasized the importance of persistence, even when there are a lot of challenges, especially last year when COVID was a major challenge and major source of difficulty. I think persistence has helped us to keep pressing on. Work-life balance was also a major issue that was discussed, and that was important for me. I think as a woman doing PhD, running clinical work and all of that, it was a very good one. Next slide, please. We benefited not just from the school, we had reunion events after the school, and these have been important opportunities for learning. We've had 3 reunion events so far, and the last was in August, and we learned about stakeholder engagement, which has been emphasized even during this meeting. We were opportune to know about future funding calls, and also the issue of multi-morbidity, mentorship, and how to write a compelling CV. And I've started using this benefits and from this information that was shared. Next slide. I have the following recommendations. One, I think that going forward, the school should also enable us to reinforce collaborations and collaborative research. This is one of such opportunities. I probably wouldn't have attended this meeting because I'm not on any GACD projects at this moment, but this coming for this meeting has been a good experience, and I think such collaborative sessions and opportunities should be reinforced among GACD alumni. Also, mentorship programs for many of us who are attending the school who are pretty new to implementation research. We still need mentorship, and such mentorship programs can be looked into. While having the small group session today, it was also mentioned that Earth economics and economic evaluation could be an important topic to include in future GACD school, information science school. And of course, the role of craftsmanship training and getting us abreast with funding opportunities is very important. And I think GACD is already doing that, and I think we want more of that as time goes on. Next slide. So in conclusion, I want to say that it was a great experience being part of the school. And I learned this African proverb, which I've heard before, but it was reinforced that if you want to go fast, go alone. And if you want to go far, go together. Next slide. So I think the Information Science School was an eye-opening experience for me, and I hope to stay focused and persistent as we have in advice so as to utilize the lessons learned and become an established implementation researcher and also help others to achieve the same. Thank you very much for this opportunity. Next slide. So I'm saying thank you and Eshion on behalf of class of 2020 and my members in group 5. That's me over there. Thank you.
Thank you so much, Aluwa Tosin, and we're so happy that you had a good experience with the school.
Hi, everyone. I'll start. So Chiri and I will be talking about our, so we attended the Implementation Science School in 2020. So we'll be sharing a few of our experiences and learnings from the school. Next slide, please. So we have just a few key points, but actually we've had a lot more, we could share a lot more. So I'll share a bit on the experiences, and then Chiri will share about some recommendations to make the most out of the school. So overall, it was a great experience for early career researchers or mid-level career researchers. So the first reason is because in this implementation science school, you can learn a lot from, first of all, the experts or the experienced researchers, but also from the participants from the school. So there were a lot of persons from different fields and different backgrounds. There were a lot of countries that were represented in the school. And in addition to that, there's a lot of resources that are available throughout the school on the platform. And then everyone is always willing to learn or very interested to learn and to share their experiences. So it's very open communication and discussions. The second point was in terms of putting theories to practice. So we learned a lot about different theories in implementation science, and We had to complete a project led by a facilitator and then with other team members and present to the in the IS school. So that was really insightful, and also to be able to work with persons who might be from a different field and different background from yours. And then the last point from my side was in terms of networking, finding mentors and forming collaborations. So that can be really useful. And personally, I still have contact with some persons, and I was really able to find mentorship in this school. So yeah, that's all from my side. Over to Chiri.
Great, thank you so much. Wow. So from the recommendations, specifically from where we came from in our GACD 2020 class, we are saying that faculty and facilitators have been a great resource even beyond the 2 weeks ISS class. So please don't be afraid to reach out to them. Keeping in touch has led to collaborative projects and mentorship, as mentioned by Claire. Again, that everyone is there to learn. So we have a lot, as Brian mentioned prior to this about the EHub. That's a resource section that has been great. It has provided a great platform to learn and interact with resources over a long period of time, and that is beyond the 2 weeks implementation science classes. It's very useful. Make it a friend. Making it a daily or even at least a weekly visit place where you learn much more than you could have learned within the 2 weeks. The reunions also that went beyond, that happened after the meetings were very helpful because we had great speakers that you could as well still interact. It fostered networking opportunities and places where you could ask people questions and continue to interact with the class that you had, the implementation science class of the 2020. Again, keep communication outside of the meeting time. So you will have specific meeting times, and depending on the time, the area that you are from, you have a span of about 3 or 4 hours. That's usually very limited. So keep that communication within the WhatsApp platforms, emails. You will work within the Google Docs to continue communicating, developing projects and protocols among your collaborators as you move beyond just the implementation science school. So that's really part of the recommendations, but I think we have a lot to share from what we did, what we had, and beyond the school last year. Thank you so much.
Well, I think Cherry and Claire just did a wonderful advertisement for the EHub, but I just wanted to encourage all of you who haven't been to the EHub Implementation Science EHub to go and check it out, because this is really your resource for you and a support for you, and the funding for this EHub comes from all of the GACD funding agencies. So this is really for all of us, and we've built this over the last year with a team here in Melbourne, Australia, but a very wonderful international advisory board from all parts of the world. And we also encourage all of you to give us feedback on the EHub when you go to it, things that can be improved, mistakes you notice, what are the gaps, what are the areas that could be improved over time, because we see this as a very important resource for the programs, like Cherry and Claire talked about in relation to the 3rd implementation science school they attended, and we're using it for the upcoming 4th implementation science school that starts in just over a week. But it's a resource that's there 24/7 for people use, and over time we'd like to really use it for more courses and programs. So please give us any feedback that you'd like on the EHub, and let's improve it a lot more over the coming months and years. Thanks very much, Jackie.
Great, thank you, Brian. I'll move on to our final showcase, and that comes from Felix, and we're looking at Recover EX Impulse Study Collaboration. Thank you very much, Felix, and I invite you to the floor.
Thank you. Also, thank you for all the inspiring presentations so far. I'm actually, quite enthusiastic about everything. So I'm going to talk about two projects that are part of the GACD family, and I'm very happy that I'm allowed to represent both of them. And that's the Recovery Project and the Impulse Project, for which we've recently explored a bit more collaboration for the future. Next slide, please. So just a brief overview of both projects. So the aim of the Recovery Project is to implement community mental health teams for patients with severe mental illness or bipolar disorder, severe depression, schizophrenia in 5 countries in Central and Eastern Europe. So where the status quo is, or the normal healthcare system, that if you have a mental health issue, you're usually hospitalized. So you're being taken out of the community and placed into a hospital. And the idea of the community mental health teams is that there's a larger focus on the recovery of the patient and functioning as well, and really provide care in the community where people live. And one of the added aspects in this project was that we included a peer expert, so a person with a lived experience that is part of the team. We also, and the Impulse Project is about implementing a technology-based intervention that helps in communication with patients with psychosis in a similar geological area. And we both focus on implementation, quality of life, also cost effectiveness, and we had a big focus on policy engagement. So we thought this would be natural to collaborate for really making a next step for these countries in community mental health. Next slide, please. And now you can click through. I think there's a few, and still click through until the tablet appears. I wanted to be fancy with the appearing icons. So the idea that we're now exploring is basically combining both projects and introducing the technology intervention into the community mental health teams. Next slide. Because we really want to gauge the momentum also in terms of the policy engagement that we achieved, to really make a change in these countries. So how have we been doing that at the moment? We've also, because of COVID, we attended a lot of project meetings for the different projects virtually, and we especially collaborated on the policy engagement. So we really set the ground for a potential follow-up project. And we're currently in the phase where we're exploring grant applications, proposals for a follow-up study. Next slide. And you can also go to the next slide because there's all the contact details. If you want to follow us or get more information, please visit our websites and our social media channels. Thank you.
Great, thank you very much, Felix, and thank you to all of our presenters who have showcased the work that's going on across the network.